Today we're going to go over a typical knee exam for patients with knee complaints of instability, locking, or giving way. So the patient is going to walk down the hall. This is the first part of the exam. And she's going to turn around and come on back. The things you're looking for are what is the angle, turn around, come back, of the foot. Is she externally rotating the foot? Is there a varus thrust where it looks like the knee is shifting out as she's putting weight on it? That looks great. Come on up here. Second part of the exam is with the patient sitting. Straighten your knee out and bend it in. Straightening out and bend it in. And we're going to check for making sure that the motion of the kneecap is symmetric between the sides. People with feelings of instability and locking or giving way in the knee, it still can possibly be because of the patellofemoral joint. So it's very important to make sure that that's part of your physical examination. I always do a anterior drawer test with the patient sitting. You do that by putting your thumbs right on each side of the kneecap and then pulling forward and testing to see whether there's excessive give or not with the tibia coming forward. And it's always very important to test that with the other side and make sure that it's symmetric. When the patient's supine, or actually when the patient is sitting, I also do a test for medial collateral ligament stability, both at full extension and at 30 degrees. And again, it's very important to test that with the other side as well. Positive complaints could be pain on the side as well as a feeling of shifting that you don't feel on the unaffected side. Can you lay back, please? With the patient supine, I check for the range of motion. So if this is 90 degrees, this is 135 degrees, her range of motion is 145 degrees, which is high range of motion. You can see it's symmetric on both sides. We're going to do what's called a Lachman test. As opposed to an anterior drawer test, a Lachman test is done normally at 30 degrees of flexion with one hand stabilizing the thigh and the other hand right at the tibiofemoral joint. And you pull forward, and you definitely test that on the other side. A positive Lachman test will give excessively when you put a stress on. You also want to do a posterior drawer test, which the leg is up and supported with the foot, and you sharply push in. And a positive posterior drawer test would have excessive give going in the opposite direction, and that's a test for posterior cruciate ligament instability. I do a Lachman type test, and then I do a McMurray's test, which is a test for medial and lateral meniscal unstable tears. So I start with putting the foot into internal rotation and doing a circular motion and then going from flexion to extension. And a positive McMurray's test will give you either a feeling of locking or severe pain on the inside or the outside of the joint. And then I repeat that same motion but going in external rotation. Then I do what's called a pivot shift test, which is another test for ACL instability, just like the Lachman test, but this is more functional. I have the patient in flexion, and then I'm stabilizing the foot, stabilizing the knee. I've got an abduction force at the knee, or a valgus force, and I'm going from flexion to extension. And a positive pivot shift test would have a severe clunk as you go from flexion to extension, which indicates that the anterior cruciate ligament is not functioning properly. When the patient is supine, you can again check the medial collateral ligament. You can also check the lateral collateral ligament, which is a very rare injury for an isolated lateral collateral injury, but it can happen. So you test the LCL for stability both at 0 and 30 degrees of flexion, and you make sure that you test both the MCL and the LCL on both sides, because sometimes patients will have some physiologic laxity, which is absolutely normal for them. I also do what's called a patella grind test, where I'll take my fingers and push the kneecap into the groove of the trochlea and see if that elicits pain. I test for their patellar laxity, where I will put my fingers on the medial aspect of the kneecap and push laterally. And there shouldn't be excessive give. So if you can get more than 1.5 to 2 quadrants out by just pushing on the kneecap, that would show that there's a patient that has excessive patellar translation and possibly would be at risk for patellar subluxation or dislocation. I also check their hamstring flexibility. We'll have it, her hip is at 90 degrees, and with her relaxed and not helping me, I'm going to get this angle, which I'm measuring this angle right here. So in her, that's about 15 degrees, which is completely normal. And we're going to test that on the other side as well. And again, completely normal. We're going to have a roll over on her stomach. We're going to do a Diol test, which is very important if somebody has a PCL injury, because you're trying to see if there's posterior lateral instability as well. So having the legs up at 90 degrees of flexion of the knees, you come down and you look at the rotation, the external rotation of the leg at different degrees of knee flexion. And a positive result would be if there's a difference in sides where there's more external rotation on the affected side, which would indicate posterior lateral rotatory instability of the knee.